Monique Reese from Sutter Care at Home. And Monique, I welcome you now to the program, and please go ahead and turn on your camera. Thanks very much. Good to see you again. You have been involved in care of elders for a long, long time, but before we get to that, take us into your present-day reality. You're the Chief Clinical Executive of a large effort, more than taking care of, as I recall, about 3,000 elders. What are you worried about day to day, this week, this month? Monique, it's possible your phone is still muted? I did the same thing last time. Go ahead.
First of all, thank you, and thanks for the opportunity to talk about AIM and the work that we've done over the last several years. So when we look at a day-to-day standpoint, I think the biggest things are really having enough clinicians to care for the volume of patients that we have, and being able to retain and recruit that workforce is really at top of mind for me from a care delivery standpoint right now.
How about looking a little bit out towards the future? What are you building towards over, say, the next year?
So a couple things that we're building is we're continuing to leverage our telesupport platform, so being able to virtually care for those patients via phone. We're looking at the use of telehealth and video telehealth in order to reach individuals, and then we're also looking at how we could leverage nurse practitioners as we're continuing to see the acuity increase in the seriously ill population.
Yeah, it's great to see you're still learning and developing the model, improving it, even though this program's been in place for several years now. That's fantastic to hear.
Yeah, absolutely. Continuing looking at ways that we could improve it and learning as we go along the way has been really important for us.
So to help us get to know you as an individual just a little bit better, Monique, perhaps take us a little bit back in your career and tell us what you've been up to and how you ended up in the position you're in today.
Yeah, so I actually started as a registered nurse in the acute setting. I was working med-surg in orthopedics, and I was in grad school during that time, and so I was going through my residency in the clinic setting and also in some specialty clinics. And it was interesting because I began to start seeing patients in both settings, and it really increased my awareness on when we would discharge them out of the hospital, what really happened. And so I started to become interested in actually that post-acute space, and in 2003 I actually moved into the post-acute space and began working in a large health system as a palliative care nurse practitioner, and really just started what I would call feet on the street, seeing patients. Started a palliative care program and then spread that across a large health system that has hospitals, clinics, and home health and across 3 states. And so just a passion, I think, to help patients and families actually stay in their home environment, should that be what they choose, and then provide the right support to those patients. And so continued to evolve, and I ended up transitioning over to Sutter Health, and I'm the Chief Clinical Executive there, and with Sutter Care at Home, and so I'm over all of that post-acute space and the service lines, and then I also lead our palliative care strategy at the system standpoint. So kind of learned just through different roles throughout the years and had a passion for care in the community.
It's so interesting that you started your story by describing sort of becoming aware of what it's really like after a patient is discharged from the hospital. I recently engaged a group in the conversation about the same patient population, and I started by saying, what goes wrong for these patients? And the response was, everything goes wrong for these patients. So make it a little bit more concrete for us. What are some of the big pitfalls in the way the system works that Sutter Care at Home is trying to address?
Yeah, so the psychosocial component, I think from a medical standpoint, a lot of our focus is really on those medical needs, whether that be symptom management and so forth. And the part that seems to be missing from a healthcare system standpoint is really how we meet the psychosocial, emotional needs of that patient and family. And so we're really focused on that holistic component and how we can actually complement that with an interdisciplinary team. And so I think, you know, our current in our fee-for-service is really I call it a churn and burn. And we're seeing them for one piece of their problem. But if you start to really dig down and understand what their specific goals are in their care, we start to see a different picture. So an example would be, you know, working with a patient that may need to increase their ambulatory ability and strengthen their quads. Yet their real goal is to, you know, make it to their mailbox, and we're trying to, you know, rehab that individual to, you know, run 2 miles. So trying to be person-centered and identify what that individual's specific goals of care are and align our care team and our resources around meeting those needs. So we're focused really specific on those types of things.
You know, during the registration process, it became very clear that people who have joined us today are interested in some of the details of how your program works, down to who are the clinicians that are involved, what do they do at work each day. Can you give us a quick overview of the team of 200 clinicians that is on the team?
Yeah, so we have an interdisciplinary team approach. It's we have oversight by a physician that's board certified in palliative care and hospice. And then currently our team really is RN led. And so we have registered nurses, social workers are our main 2 care team members. And then we also pull in chaplains and other resources from a PRN standpoint. But the main team's comprised of registered nurses and social workers. We are looking at next year beginning to add a complement from a nurse practitioner standpoint. We're continuing to see that acuity rise in that community and home setting, and so we will be adding nurse practitioners that can make home visits and starting a home visit portion of the program also in 2017.
Can you take us from the patient's perspective through what happens from the moment they're referred into the program?
Yeah, so how the program's designed currently right now is they could be referred in multiple areas, and it's really based on when we identify a need. So an example could be they have a home health episode of care, and the home care case manager identifies they would benefit from additional resources and they meet the criteria. We may complement that team with an AIM trained clinician. Or they could have an acute stay, and during that acute stay they're identified and meet criteria, and we'll actually bring in a registered nurse to facilitate the discharge planning, the care in the hospital, and actually focus on that specific person-centered goals of care and so forth. So we allow entry into the model from a clinic, from a hospital standpoint, from if they're in a home care episode of care, and also the ability to tap into the telesupport. So that patient would actually, we would do an assessment, an initial assessment, identify what their goals were from a goals of care standpoint, and really from that goals of care, we start the conversation in regards to putting a care plan around to meet those goals of care. And so a patient would see that first initial and then we really adjust based on the acuity of the patient, how much upfront we do from a face-to-face visit versus how much telephonically and so forth. And as they navigate through, we're really trying to teach self-management. So we may be doing face-to-face visits with that individual in their home, and they actually transition into telesupport, and we have the RN actually calling on the phone versus making home visits. So that could be kind of a normal course. When they are stabilized and we see that self-management and the capability to actually teach back and demonstrate when to call, is when we would really look at, would we discharge them to self-care, or the other direction could be if they continue to decline and their goals of care are aligned with hospice services, we would align them and refer them into a hospice program if that's what they choose. So that's a little bit of detail on some pretty common paths for patients.
Yeah, I imagine it must take some training for the Advanced Illness Management Program, the AIM program staff, to become comfortable with goals of care conversations.
Yeah, so we have about, we have a 5-day training for anyone new coming in. And there's some core principles we train on, and those are best practice type principles, so things like health literacy, motivational interviewing, teaching red flags. We use a stoplight approach in regards to symptom management, follow-up visits and the expectations for if an individual is hospitalized, that we make a follow-up visit in 5 to 7 days with their primary care provider, and then best practices in regards to use of telehealth and transition. So that's kind of what I would call a foundational education and competency testing that we provide. And then layered on top of that component is really best practices from a symptom management standpoint and goals of care discussions. And so that training actually happens over a 5-day period when an individual is new into the program.
It came up in our earlier discussions that one of the challenges for new staff in the program is sort of shifting their mindset from an episodic mindset, I deal with the patients that are in front of me on any given day, to taking sort of more longitudinal responsibility for their panel of patients. Well, how does that come about? How does that change in mindset come about?
Yeah, so some of that kind of gets into what I call care management principles. And so managing an individual across care settings and across time. And so what we've learned is certain clinicians are made to do that work, and certain clinicians don't necessarily enjoy that work. So we're really looking for individuals that understand comprehensively the care continuum and have some experience across the continuum of care. And so it gives them a little bit more holistic picture of how care is delivered in a health system or across the health system. And then, I think as important is, that clinical skill set in regards to evidence-based practice and application of evidence-based practice, whether that be symptom management control or having a goals of care discussion with both the art and science of that. So it's definitely being able to identify and choose clinicians, I think, from a purpose and a passion that really want to be in that work and understand it from a continuum standpoint.
In the very formative stages of this program, there was a recognition that, gosh, we've got a clinic, we've got a hospital, we have a home care team. They're all doing good work, and yet they're not talking to each other much. And coordination of care has always been a big goal for your program. Talk a little bit about the protocols or the strategies you are using to keep everybody on the same page and everybody informed.
Yeah, so one of the first things we did is we actually embedded the care plan in the notes in our electronic health record that our physicians can see. So when we're out, whether it's in the home or in the hospital setting, we actually notate the care we're delivering, the goals of care and so forth in that electronic health record. And we really use that electronic health record as that platform for what I would call the source of truth. And it identifies that individual's person-centered goals and maybe some of the issues that we're dealing with or helping the patient with. And I think that's central to care coordination, and the ability to do that is actually how you communicate, and then how all of us across the continuum can use, one central platform to actually provide that communication. So I would say that's a key point in the success to coordinate care, is the care plan. We do have a pillar approach to that, and we focus on 5 different areas in regards to what we notate. And we do that at a minimum once a month. So we're always updating once a month for that pillar focus note. And that has things like what the individual's person-centered goals are, any type of red flags that the individual is displaying or that we're managing, and several other items. So I think that's one of the key things. The other would be what's the right amount of care for the individual. So I think I mentioned earlier, you know, is it in-person care? Are we doing this telephonically? We'll be adding telehealth to that component in the future, which I think will be great from a video standpoint. And so really being able to understand that and being able to articulate that back to their primary care provider so that we're there to be a resource and a support to that primary care provider in managing that individual's chronic disease and not add a layer, per se, of additional burden on that patient or that provider.
I want to make sure that I understand what the pillar-based approach is. I think you called it. You have a strategy, as I recall, for creating notes with 5 distinct sections in them that you're calling pillars, starting with goals of care. Is that right?
Yeah, so the 5 pillars that we have built a foundation on for the note is advanced care planning. And so, you know, our goal initially as we came out was that 90% of individuals had completed advanced care planning, and that was actually available from electronic health record. And so, you know, we're at about 99%. That's actually one of the things that we're doing very, very well. And the thing that's interesting with that is that during, we do a pre and post 90-day look back, and during a 90-day period, over 60% of individuals change their advanced care plan based on, you know, what's going on in their life. And so it isn't a stagnant document, like something that you fill out and you shelf. It's a continual conversation based on the journey that the individual and their family are on. So advanced care planning is one piece of that pillar. I mentioned the red flags and symptom management plans. We have medication management as part of that pillar note. And then the 2 final are the follow-up visits. I think I mentioned that earlier. And then where that patient is from a self-management support standpoint. So do we see them self-managing successfully, or are they having difficulties, and how much support do we have to provide? So every, at least at minimum, once a month, we are updating and documenting in those 5 pillars. And that's available in the electronic health record for the primary care provider.
Yeah, it sounds like a great way to ensure everybody who's involved in the care of a particular patient can very quickly get up to speed on what's going on with that patient along so many different dimensions. Going back to sort of some of the operational mechanics of the program, I'm thinking, again, from the patient's perspective, how many different clinicians might they get to know who are involved in the program? Is it just one nurse that's going to be the primary person, but then others, perhaps if the nurse is not on duty at a particular hour? How many different people are involved?
So depending on the patient needs, there could be anywhere from 1 to, they would be transitioned to 3 or 4. So we actually don't have a primary only one person type model. We use the interdisciplinary team model, and it is RN led. So they may have an RN and a social worker that's actually working with them. When they transition, so let's say it's a face-to-face visit, if they would actually end up transitioning to telephonic support, that would be a different nurse. But there's a warm handoff that happens in a conversation and an introduction that actually happens to do that handoff. So we did not take an approach that one person would do all components through that continuum. We do have a team-based approach.
Yeah, I mean, it seems like one goal, you mentioned the stoplight, one goal of the program is to make sure that patients are properly alerted to a need to call and to ask for help. Do you feel like patients have enough of a personal connection with the staff that they're always comfortable doing opposed to calling a doctor, their family practice doctor, or going to the emergency room?
Yeah, so our experience is that the connection with that lead nurse, they do feel comfortable calling. I would, some of the learnings that we've had is when we talk about red flags, for example, and we're teaching that when you're in the red zone, give us a call. You know, we would experience when you're in the red zone, if they would call a primary care provider and maybe the office staff wasn't aware of red, yellow, green type zones in the language, it could cause some confusion. So you can see some of the continual work that needs to happen in regards to what I would call using some of the same language across the continuum of care, at least within a health system that you could manage that. So we do see them in calling, but that's a journey, and everybody moves through that journey in a different pace. Some people, you know, are able to actually be confident that they can identify if they were having an increase in symptoms, and other it may take, you know, a couple weeks to actually do that. So it's very individualized, but we do see that connection with the clinician and a relationship being built and a rapport being built, which is key.
Absolutely, and thank you. I want to remind everyone, if possible, to be sure that your phone is muted unless you're talking, as I'm hearing some noise on the line. So if you would check, that would be great. I also want to thank Jim Henning, who I know from his participation in a program here at Dartmouth, for asking our first question via the chat window. Jim's interested in strategies you might use to collect lessons learned or insights from the experiences of the now 200 clinicians in your program. How do you sort of capture all those insights and use them to help guide the program?
So we actually have weekly care conferences, and they're in each of our locations. So we're across 19 counties, and so they're across each of our locations, and we have weekly care conferences, and those are actually documented. And so we're able, through those care conferences and the leaders of those care conferences, able to identify where we may have opportunities, both from a patient care delivery standpoint or a practice standpoint, and also where we have opportunities in regards to possibly not following process or not being aware of process and so forth. So we actually have a quarterly reporting that we have. We have over 50 metrics that we track, and we're able to, from a quarterly standpoint, track trend metrics. And based on that, we put performance improvement plans in place on whether or not we're meeting targets and so forth. So it's quarterly reporting, and then we go through that normal PI process. So it seems to, when we start to see a trend, it's interesting because it may be different based on location and so forth. So we really try to individualize it on that individual, the trends at that individual location. So, but we can also look globally. Do we have a global opportunity? So, for example, you know, in the last year, we've seen a decrease in the referral to hospice. And so we kind of started to look at that, and we thought, are we moving upstream more, and that's why we're seeing a decrease? Or do we need to go back and provide some education in regards to conversations and also appropriateness? And so we actually looked at that, dug into the data, and what we really need to do is go back and provide some more education and do a refresher education for conversations and criteria. So that's just an example of that. It's continuous performance improvement. And, you know, I mentioned a little bit adding nurse practitioners next year. And so we're at a quarterly and an annual basis really looking at what's working, where do we need to improve, and what do we need to change.
Yeah, Monique, you mentioned all the different locations, and it reminds me that I hadn't necessarily made clear the geographic reach of your program. You're in Northern California, but be a little bit more specific about just how spread out your AIM clinicians are.
Yeah, so we are, we're in Northern California. We're in the Valley area, in the Bay, so Sacramento, all the way over to Santa Cruz, And so depending on traffic, it could be a 6-hour or more spread. So it's a large geographic area that we are in. And in each of our locations, we have, most often we have acute hospitals, we have our medical foundations and our medical groups, and home health, hospice, pharmacy infusion service lines.
You also teed up another question that I know that several people are interested in by mentioning all the metrics you look at. Could you be a little bit more specific about the metrics that you find are most meaningful in guiding your program forward?
Yeah, so there's probably about 5 metrics. I mean, if you narrow it down, that we're looking at often, and we actually benchmarked some of that against a JAMA article in 2013, and it was change in the end of life for Medicare beneficiaries. When we look at our mix of patients, probably a little close, around 70% are Medicare patients. So we're looking at percent of hospital deaths, and we're looking at hospital days in the final months of life. We're looking at ICU days in the last 30 days of life, transfers to hospice, and proportion admitted for hospice care for less than 3 days. And so those are, the 5 we look at often and that we have at our fingertips. And so when we look at, for example, Q1 of 2016, the patients enrolled in AIM, about 11% of those individuals died in the hospital setting, and the national benchmark is about 25%. And then hospital days and final months of life, we look at patients have spent about 7.6 days on AIM in the last 90 days, or the last 6 months, and the last 90 days for the national benchmark is 8.2 days. I know that's not apples to apples, but it gives us a little bit of a comparison. For our ICU days, we have about 6.9% of patients in the ICU in their last 30 days of life, whereas the national benchmark is a little over 29%. And then our transfers to hospice are about 53% of our patients transfer to hospice, whereas the national benchmark is a little over 42%. And then admitted to hospice care for less than 3 days, it's only about a little less than 11% for us for our AIM patients, and that national benchmark is closer to 29%. So those are the ones that we keep at our fingertips, and we're kind of looking at how are we doing in regards to caring and managing for that patient.
Yeah, those are terrific statistics. You do so much in terms of goals of care. I wonder if it's universal that people will tell you that they don't want to spend any time in the hospital or certainly the ICU in the last days of life, or is it somewhere short of universal? Some people will tell you, I'll go down fighting to the last breath.
Well, it's not universal, and I think taking that approach from a person-centered standpoint is important, but I would say a majority of the individuals we care for and their families want to age and die in their home environment, wherever that may be. I mean, sometimes that's a home, sometimes that's a boat. It just depends on where that is. But a majority of patients want to be in that home setting. But I wouldn't say it's universal and that everybody does, but definitely a majority of patients that we've cared for. They want to stay as independent as possible. They want to be comfortable. They want to be with their family.
We have a Dr. Sean Uterich who's asked the natural follow-up question, have you done any work measuring adherence to articulated goals of care as opposed to just trends in the overall population?
Yeah, so we actually embedded in our electronic record area where it states what that patient's goals of care are, and we're able to go back to say, did they meet that goal of care? So when we go to discharge, we're actually documenting and going back to what their goals of care are and were they met. So it's a goals of care were met type documentation. So we are going back to that person-centered goal to look at did we meet their goal or not. And then we are able to then go back and coach and mentor from a performance improvement standpoint. Was this an appropriate transition, and where could we have improved? And what I would say is we do have opportunity for improvement in that area, and going back to the goals of care and keeping that central.
You know, a related question that came up during the registration process was whether you've collected data or survey data perhaps from families to assess how satisfied they are with the care and its adherence to goals of care.
Yeah, so actually we do, and what we've seen in, I think it was, I was looking at the quarter 1 of 16, is we were seeing about a 90% satisfaction rate from a patient satisfaction standpoint.
You know, another area of interest was that comes up a lot in the work I do is how do we translate what works in areas with a high population density to more rural areas. You came from Iowa, as I recall, certainly a rural state. What are your thoughts there? Can you take this kind of care into low population density areas, or do you have to make some adjustments?
You know, we do go into rural areas. Some of my experience, both in the Midwest and California, especially northern areas where it is rural, is the resources that are available in the community. And that's both from an employment standpoint, so the ability to recruit and retain a clinical team in an area, and also what type of resources you can leverage in that community. So it does become a little more difficult the more rural you get and the less resources you have in those communities. But we are providing and sending teams out. One of the things that we're really focused on is being able to hire those care teams locally. So we really like to focus on individuals that live in the community that they're serving or live near the community that they're serving. So I think the biggest barriers or opportunity in some of those is really being able to have the access to those care teams and being able to hire that resource. And I think that's where telehealth is going to come in and really help to bridge some of that gap and look at the opportunities on how can we virtually provide some of that, and then at the same time send a care team member out there. And as you know, Northern California is pretty large, so that that could be a couple-hour drive to get to some of the areas, depending if you're going through the mountains and so forth.
Tim Hennings asked another interesting question. The patients that you serve, estimated to be in the last 18 months of life, certainly have a lot in common. They need to think about goals of care. They're getting quite ill. They need continuing care, not episodic care. But he wonders if there might be value in segmenting the population further, say by medical condition. Is that a possible direction you might be going in down the road?
So in regards to like specialty care, so maybe give me a little bit more information.
Sure.
So I can.
I would guess that a fairly significant proportion of your population has a diagnosis of congestive heart failure. Is there any movement towards creating teams, clinical teams, that focus only on that subsegment? Does that make sense? Yeah.
So we haven't moved in that direction from what I would call a specialty type service line. So the primary diagnosis, let's say, may be heart failure, but most of the patients we care for, in fact, a large majority have 2 to 3 chronic illnesses. So we're not seeing those individuals that they only have 1 chronic illness. Almost all of our patients have at minimum 2, and most have 3. So we aren't going down to have specialty tracks in regards to a team that specializes just in heart failure management.
Thank you for that. Another area of interest for our audience, I know, is the role of primary care physicians in the overall care picture. Just what is their role?
So I mentioned a little earlier in our discussion that we're there to actually partner with that primary care and provider physician, and So they're directing the care, and we're in constant conversations. We're leveraging that electronic health record to keep them up to date on the care that's being delivered and the way we're delivering that. And so they're central partners of that care team in regards to the patient care and so forth. So we really look at it as a full partner. They're helping to drive that care. They're making referrals to us. And we're really that team that goes across the continuum to really help them manage the seriously ill. So that's our approach in regards to the partnership from a primary care standpoint.
I know that referrals, simply referring patients to the program is a tremendously important role for them. What criteria do you want primary care physicians to follow to judge whether a patient is appropriate for your program?
Yeah, so as we started out and we wrote the criteria in our grant application from a CMMI standpoint, we actually started out with individuals that have a functional decline, that have multiple rehospitalizations, and so we focus more on what I would say some of the utilization measures, and that's how the CMMI application was actually written. We are looking at currently how we can change that. So our focus was on high burden of disease, and they had to have one of the following. They had to have a rapid, significant clinical, functional, nutritional decline. They needed to have recurrent hospitalizations or ED use. And it was that surprise question that the provider would not be surprised if the patient died within 12 to 18 months. I would say that we are looking at, from our learnings, actually being able to move upstream a little bit further than where we are. And so from a primary care provider standpoint, make it a little bit easier and automate that approach in regards to the patient identification. So we actually have a care team now that has analytic support and so forth that's working through what did we learn from the eligibility criteria and what can we do to improve upon that. So trying to get more predictive in that course.
Okay, but to date it sounds like the criteria are subjective and it's left to the judgment of the referring physician. If that's is that a fair summary?
Yeah. So we do have. So to get it in a little bit more detail, we could look at loss of ADLs over a 90-day time period, decrease in bathing, continence, dressing, feeding, patients having nutritional decline, so they've lost 5% of their body weight over a 6-month period, or the albumin is less than 3. So the hospitalization was 2 or more hospitalizations within the last 6 months, or 2 or more ED visits in the last 3 months. So those were like the more specific criteria that we look at.
Mike, which of the primary care physicians in your network are happiest with you, and if they're really happy with you, why? And if there are a few that are perhaps unhappy, what would the reason be?
I think we're partnering well with our primary care physicians. We definitely have strong relationships from a hospital standpoint in the readmission movement and improvement from the acute standpoint. And so I think there's a lot of opportunity, though, for continual education and what I would call primary palliative care across the clinic offices. And that is a system initiative that we're focused on working on, is that really education from a primary palliative care standpoint. I think, the question in regards to how does that relationship work with the providers is extremely important, in that the physicians and groups understand that the team's there to actually support the management of that patient versus actually take over the management and own that patient. So I think always keeping that clear and front and center has been really important.
I want to turn to a topic that I know interests lots of people on the line, and that is how we finance this program, how we continue to pay for it. It's tough, right? So many of the innovations I've been covering are good, they deliver great results, and yet they're hard to pay for. You had one of the things that really jumped out at me and got me excited about your your program, the AIM program, is simply its size. You managed to grow it to 200 clinicians, 3,000 patients. That's pretty extraordinary in my experience. Apparently a grant was a big part of that. My question for you is this sustainable at this point with your current mix of value-based and fee-based contracts?
So, a couple things from a history standpoint. When we started on this journey, it was in around 1998, and it was more of a advanced care planning type approach. And so through the years, it continued to evolve. And some of the key goals of the grant, which we received from, it was a CMMI, and that helped fund the spread. But the primary goals of that grant were focused on enrollment, so increasing access to care, being able to spread across a geographical area, and payer savings. So those were the three primary targets for performance that the CMMI grant was looking at. And so we were funded, we received over a 3-year period over $13 million, and then we also had funding from the health system that assisted. That actually ended last year in June of last year, and so it's actually been self-funded from a health system standpoint since that time. And so what we started to do from a transition off of a grant program into a sustainability program was really look at some different opportunities. One would be payer contracting. So we do have commercial 3 commercial contracts in relationship to payment. And then the other is fundraising, is fundraising and looking from a community standpoint. And then the health system is also supporting the program. So, when I think about key targets in sustainability, we're looking in multiple avenues. It's not just one way. We're also billing when physicians go out, and we will be billing for NPs, but I think anybody that runs programs like that know that you're not going to create enough revenue to support a program, at least in the community standpoint, from that standpoint. So we're looking in multiple ways on how we continue to fund. A key thing for us is that the CEO and of our health system is very supportive of the program, and so that's always good as you move off of the grant funding into self-funding.
Given the dramatic reductions that your program is demonstrating in ER visits and ICU visits and so on, the statistics that are in the article are just extraordinary. I would think, given that payers would be bending over backwards to keep your program alive. Has that been the case? And if not, what is your perspective on what's getting in the way?
I thought about how to answer that question. So I think for us as a health system, we're around, I believe, 20% of our patients are in a risk-based type contract. And so other than that, we're still heavy from a fee-for-service, and like most organizations, on that journey to be more value-based and value-based contracting type arrangements. And so we do have 3 contracts that we're working with right now in regards to delivering AIM from a program standpoint or a product standpoint. I think there's still development both from the payer side and from the provider side in regards to how you actually partner to do that and how you share the savings. And so I wouldn't necessarily say there's a ton of jumping in, at least from my experience, both in the Midwest and here, that payers are running to a capitated type model, at least at this point. I think there's probably still opportunity for us to move there in a quicker pace, but at the same time, I don't know that providers are really ready for that too. So I think on both sides, there's still maturity that needs to happen before we're running to it.
Well, I'm certainly eager to see an acceleration of the pace of change in the payment model. It's absolutely the linchpin for growing and expanding so many of the great programs like yours that we've been talking about on this website. If it's okay, I want to take a bit of a right turn here to honor a question from Vinay, who's interested in your hospice network and whether that's Sutter-owned or if you're working with independent hospice networks as well.
Yeah, so we actually have a Sutter-owned hospice network in each of our locations, and then we also partner with other community-based and/or privately owned hospice organizations. So as we go through that process, we offer choice, and based on that patient's choice, we set that up for them and connect them to the hospice of their choice. So we both work internally and externally.
Are you able to improve the coordination of care when you're working internally in some ways?
Yeah, I think the internal part of the coordination, absolutely. A lot of times those clinical teams will know each other in the geographical location. Again, I think I mentioned trying to keep those teams part of that community and local. So a lot of times they're working together and know each other, but we definitely aim to coordinate it no matter if we're working with a Sutter hospice or externally.
Yeah. I want to give us a chance to sort of pull back and reflect on where this program has been and where it's going. I know that when you arrived, one of the first things you did was ask, gee, what have we learned so far? If you had to pick out a few most crucial lessons learned from this program's history, many years of history now, what would the lessons be that you'd highlight for others that perhaps are thinking about launching a similar program?
When I know there was a lot of interest in the operational component, so some of the areas that I was looking at as learnings over the years that were hard operationally were, deciding on the order of how we spread. So I mentioned the geographic spread goal from the CMMI application and grant. And so, what we ended up doing was basing that on readiness of the location. And we started with the easiest and then went to where we thought it would be the hardest. So just trying to figure out the operational spread was a learning that we had. We had a rapid rollout schedule, and that put a lot of demands on hiring and recruiting. I mentioned, depending on the location and the availability of clinicians in those areas, so that the recruitment, the hiring, the orientation, the preceptoring, and actually having that hardwired and embedded was a learning for us and how rapid that was. Building the infrastructure to manage the data was a huge effort, and so we were working on a weekly and a daily basis, and actually how do you do that, how do we monitor it, how are we going to track it, and so I think those were probably the biggest things from an operational standpoint that we learned, and I think if we would look back, having some of those things set up prior and ready would be beneficial, but a lot of, as you go into that spread, there was a lot of intense focus in the beginning of that and efforts that took place to actually have that be successful and roll out in a successful way.
Monique, one thing I note about sessions we do here is that the hour always flies by, at least for me. You've covered a lot of ground. You've left us with a lot of insights. It's been terrific listening to you. Thank you so much for joining us today. Is there anything, any last thought you'd like to share with the audience, perhaps where they could go for additional information about your program?
Yeah, so you could go on our Sutter Health website and pull information from the Sutter Health website. It'll be out there if you look at it. There's a lot of content that's out if you just do a search on AIM. And then I can also, I don't know if for sure you have my email on there, but if anybody had any questions, I definitely could send me over an email, and I definitely try to help get any kind of information that you would request or need.
There'll be a thank you email going out to everybody who participated today, so I will include your email address there, and thank you for offering it. And thank you so much for being here today, Monique. For everyone else, thank you for joining us. I'd, of course, like to thank my sponsors here at Dartmouth who are making this program possible.